So we'll get started. Welcome everybody. This is the Neurotology Eastern Region Virtual Education Series, and today we're hosting Dr. Cal Cunningham from Duke University, who's going to be talking about current trends in Stapes surgery. Thanks so much for joining us, Dr. Cunningham, and I'll turn it over to you.
Thank you, Mallory. Thank you for having me. I'm going to be discussing some of the current updates and trends in surgery for otosclerosis today. I do not have any relevant financial disclosures related to this talk. Just to give you a little bit of background about myself, I'm Cal Cunningham. I'm a neurotologist at Duke University. I did my medical school training at the Medical University of South Carolina, followed by a residency in ENT there, and then completed a fellowship at the House Ear Clinic in Los Angeles before moving here to Raleigh. I actually was in a private practice for about 7 years before joining Duke, and I've now been at Duke a little over 10 years now. So with that, what I'd like to do today is just talk a little bit about some historical background regarding otosclerosis and Stapes surgery, and then we'll discuss some preoperative considerations. We'll look at the various surgical techniques currently being used, as well as some controversies in Stapes surgery, and in particular, controversies regarding certain patient populations. And then we'll kind of follow up a little bit about postoperative care. So, of course, no talk is complete without a little bit of historical perspective. Valsalva was actually the first to describe Stapes fixation as a cause of hearing loss, but at the time, they attributed this to sort of more of a chronic ear problem, and they called it dry catarrh of the middle ear. And as a result of this, the thought was that these patients with these chronic ears would ultimately get secondary Stapes fixation. Von Troelsch in the late 1800s, he was really the first one to describe otosclerosis or use the term otosclerosis to describe hearing loss associated with Stapes fixation. And he thought that these were, this was the result of sclerosing changes that affected the mucosa surrounding the stapes, and that this was the cause of the fixation. And then Adam Politzer, he was really the first to describe the actual clinical picture of otosclerosis related hearing loss, as well as both gross and microscopic pathologic changes. He was really one of the first to counter the belief that this was a middle ear catarrh or sclerosing phenomenon in the middle ear. And he thought it was more, he really was the first to report that it was more of a bone disorder of the labyrinthine capsule or a dystrophy of the bone. But the actual true, histopathologic condition really wasn't described until the 1900s, 1912, with Siebenmann, when he described this sort of spongy change that was occurring in the bone around the cochlea and around the oval window. And so he actually coined the term otospongiosis, which is really a little bit more of an accurate terminology for it. However, otosclerosis really has kind of stuck. And some of that is because, as you probably recall, there's two phases to otosclerosis. There's the initial otospongiotic phase, in which you have this infiltration of blood vessels into the bone, and that's when it becomes sort of this spongy matrix. But then you get a regression of all that vasculature, and that's when the bone actually becomes sclerotic. Now, if we look at surgery for Stapes fixation, Johannes Kessel is really considered the father of Stapes surgery and was the first to report both Stapes mobilization as well as Stapedectomy procedures. But as you can imagine, it was pretty rudimentary at this time, and a lot of times the way they treated it is they would just extract the Stapes completely and then create some sort of flap with the eardrum to lay down over the oval window. Frederick Jack here in the United States in Boston, he reported on 70 cases of Stapes extraction with no oval window coverage at all. So they just took out the Stapes, allowed a blood clot to form there, and then in a lot of these patients, they actually healed up with a significant hearing improvement. However, as you can imagine, especially at the time without a lot of antiseptic use or antibiotics, there were often cases of meningitis. And so as a result of this, at the 6th International Congress of Otology in the late 1800s, they sort of decreed that Staphy surgery was useless. It was often mutilating and dangerous. And this sort of discussion about whether surgical therapy should be applied to otosclerosis was sort of put down for quite a while, and Staphy surgery was abandoned for a period of time until Julius Limpert came along, and I think most of you probably recognize that name, if nothing else from the Limpert elevator. But he was known because he was really the first person to design a very consistent approach to treating otosclerosis, and this was the fenestration procedure. Now, he wasn't the first one who've actually described fenestrating the semicircular canals to improve hearing, but it typically had to be done in either 2 or 3 stages. One of the first stages would be just to create a canal wall down mastoid cavity, and then later you would come back and make the fenestration. And he developed a single stage approach to fenestration. He also was one of the first to use a electric drill to do this, and it provided a pretty reliable and predictable hearing gain to 20 to 25 decibels in greater than 50% of patients. So it wasn't perfect, but it was a significant improvement over what they were used to at the time. And as a result, the fenestration became kind of the accepted procedure throughout the world for managing otosclerosis. And every now and then you may come across still an older patient, there probably would be in their 80s or 90s, who has a canal wall down cavity and has had a fenestration operation, but there's not too many of those out there. And then, of course, John Shea in the 50s, he really brought about sort of the next revolution in management of otosclerosis, and that was the stapedectomy. And he was the first to sort of conceive this idea of removing the stapes, covering the oval window with some tissue, and then placing a prosthesis. And some of his first attempts he did just using a bone strut, but then he went to an engineer, Harry Treese, who was with Richard's company, and they were based out of Memphis. And he had him develop this Teflon Stapes prosthesis here. And so he actually took him a bunch of Stapes bones that he had extracted from cadavers, and with these, he created this Teflon prosthesis. And so the smaller opening at the top would actually, you'd have to kind of slip that on and over the lenticular process of the Incus. As you can imagine, it was pretty difficult, and they didn't really make separate sizes for this. So there were issues early on with the getting it on the Incus, but also the length. And ultimately, he ended up using just a piece of IV tubing that he would shape into a strut. And so this is kind of a description of the original stapedectomy as described by John Shea. And interestingly, not a lot has really changed in that. The initial portion of the procedure involves separating the IS joint, and then cutting the tendon here, down fracturing the superstructure, perforating the foot plate either with multiple perforations or a single perforation, and then kind of using a hook to fish out the segments of the foot plate. Once this was done, a tissue graft, of course, is placed over it. And then this is kind of what that original prosthesis looked like. This is basically IV tubing that's been beveled at one end, and then the open end is sort of trimmed to create a little cup portion that will fit on the lenticular process. In addition to total stapedectomy, there is partial stapedectomy, and this is still used in a lot of places. So instead of removing the entire foot plate, only the posterior half of the foot plate is removed. And then again, a tissue graft is placed over it, followed by a prosthesis. This would be a nice example of a bucket handle type prosthesis. And then this was followed by, of course, small fenestra stapedotomy, which I would imagine the majority of surgeons are using today. These two pictures demonstrating the use of a laser to make a rosette on the foot plate, followed by a small fenestra. Now, this is just a video demonstrating a kind of a pretty standard approach in a laser stapedotomy. So an IS joint knife is first used to separate the joint. This is an OmniGuide CO2 laser, handheld laser probe using to cut the stapedial tendon. And then this is the posterior cruce of the stapes, which is being lasered. Rarely you'll find a patient whose anatomy allows you to actually cut the anterior crus. A lot of times you end up having to just fracture the anterior crus because it's difficult to actually get to that with the laser. In this case, actually, I was able to cut that anterior crus and just gently kind of lift the superstructure out. And then this is a pretty standard measuring guide or measuring rod. The way that is used is that little tab is once the rod is on the foot plate, the tab should be at the level of the top of the incus. And then the laser being used to make a rosette pattern in the center of the foot plate. This is a rasp, a 4mm rasp. It's just like a little disc on the end of an instrument. This is what I actually like to use now to make the fenestra. Other options are a little perforator or a drill to make the actual fenestra, but this is pretty gentle, and basically you're just using it to kind of smoothen out the margins of your fenestra. And then a pretty standard Teflon piston type prosthesis. This in particular is a Nitinol. It's an Olympus piston. So that wire loop is a memory shape alloy. And when you hit it with the laser, it sort of self-crimps onto the incus itself. And then finally, just a little bit of subcutaneous tissue is placed around the base of that piston. So next, we'll talk a little bit about some preoperative considerations. One of the questions is always, well, when do you operate? This would seem like, a pretty obvious patient to operate on. They've got at least, 40 or 50 decibel air bone gap here between their bone conduction line. They've got kind of a typical Carhart's notch here at 2000 hertz, and they have absent acoustic reflexes. One thing I always emphasize to our residents, as well as fellows, is that anybody with a conductive hearing loss, it's really important to make sure your audiologists are doing reflexes. Because if it's a milder conductive hearing loss, you don't want to get in there and then find out that it's not otosclerosis, it's something else like a superior canal dehiscence. But what about this patient, though? This is a pretty minimal air bone gap. And, I was always taught that you rely on your tuning forks. And once that air bone gap reaches, a good 25 to 30 decibels, that's usually when your tuning fork will reverse and bone conduction will become greater than air conduction. But a lot of these patients, even with hearing loss like this, they can be pretty bothered by it. They really feel like it's affecting their hearing and they're not doing well. And so, if we look at kind of the Academy's position statement, typically patients should have a pure tone average greater than 25 decibels and an air bone gap greater than 20 decibels. With your tuning fork, bone conduction should be greater than air conduction. However, there's been a couple of studies looking at these patients who have milder conductive hearing losses. This one by Lippi and colleagues looked at patients with an air bone gap of 10 decibels or less, and the mean pure tone average hearing improved by about 16 decibels in these patients with an overclosure of their hearing by about 8 decibels. So they do receive significant benefit. Here's another study in which they looked at a larger group of patients who had an air bone gap less than 21 dBs, and 97% had a post-op air bone gap less than 10 decibels. And so, in addition, there was some overclosure in their bone conduction scores in about half of the patients. But you have to keep in mind these patients have milder degrees of Stapes fixation, so there is a risk that you might end up mobilizing the Stapes during the initial portions of the procedure. But and my take on this is, in general, I tend to be a little more conservative and recommend that these patients wait until their hearing gets worse. But occasionally I will have someone who's really pretty significantly bothered and they really feel like they're having, increased difficulty, especially background noise, things like that. And I will discuss with them surgery, but also discussing there may be some other risks involved. Looking at some just variations in the surgical technique itself, let's look at anesthesia, general versus local. I favor local, and when I say local, I mean kind of like monitored anesthesia care, so IV sedation. But I think this is a lot easier on patients. If it's a difficult case or certainly something like a revision, you can kind of assess the patient, keep them lighter, and if they're having vertigo, they can tell you if they're having issues. It's less expensive, of course, than general. You have a much reduced risk of post-op nausea and vomiting. However, on the downside, these patients, they might get light. They can sometimes move. If they're, heavy set, snoring and breathing difficulty can sometimes make it a little bit of a challenge. And of course, if you're teaching residents, it's a little bit more difficult if the patient's light or awake, and they're able to hear what's going on. On the other hand, general anesthesia, it's reduced discomfort at the time of surgery. It facilitates teaching. Patients are more stable, but as mentioned above, it is a little bit more expensive. The one thing I do always get concerned about, especially with general anesthesia, is they have a little bit more post-op nausea, vomiting, and you really, in this patient population, you don't want them vomiting or straining real hard after surgery. There's several studies that have really looked at both of these, general versus local, and in general, there's really not any big difference in the outcomes. In this one study, they had a 1.8% incidence of a dead ear, which is pretty minimal, and probably if you look at a larger number, it may ultimately pan out between those two. There really is no difference in the hearing results as far as post-op ear bone gap, sensory neural hearing loss, or post-op vertigo. We actually did a study. This was back in 2018, and we surveyed members of the Academy as well as members of the ANS about their various preferences regarding Stapy surgery. And in particular, we asked about how they like to give anesthesia, and overwhelmingly, 74% use general endotracheal anesthesia, and 22% MAC type anesthesia, 4% just local anesthesia. So maybe have the patient take a little Valium before surgery and then just localize them with local anesthetic. Looking at the various approaches, of course, there's the standard approach typically is a transcanal approach, but a lot of people do like using endural approaches. This is very popular in Europe, and US surgeons who've trained over there also like to favor the endural approach. And then, of course, more recently, as with other parts of ear surgery, endoscopic surgery has become popular with Stapy surgery. If we look kind of at just differences in the technique itself, stapedectomy versus stapedotomy, here again, stapedectomy, removal of either partial or the whole foot plate versus a small fenestra stapedotomy. We really don't see a whole lot of difference, certainly not in hearing outcome between those two. This is a study by Lauren Parnes and colleagues. They compared stapedectomy to stapedotomy, and really did not see any major differences in hearing outcome. One thing notable, though, stapedotomy does seem to provide a little bit better closure of your high-frequency ear bone gap when compared to stapedectomy, and and stapedotomy also may have a very slightly lower rate of sensory neural hearing loss compared with stapedectomy. And if you think about it, it kind of makes sense. You're doing far less manipulation of the foot plate and the inner ear fluids when you do a small fenestra stapedotomy. I also think, when you take out the whole foot plate, that you may get a ever so slightly increased bleeding involved with that, and that blood in the vestibule can sometimes elicit a little bit of a serous type labyrinthitis. If in our survey we kind of looked at the proportion of surgeons doing stapedotomy versus stapedectomy, and 3/4 today are now using stapedotomy procedures compared to 25% basically still doing stapedectomies. A little bit about endoscopic stapedotomy. Endoscopic ear surgery certainly has advantages. You have a wide-angled view that's very nice and clear. You have improved illumination. With an endoscope, you can get in there and see things that you may not see with a direct line of sight with a microscope. In general, more frequently, you don't have to remove as much bone from the scutum, and you may, as a result, you're not manipulating the chorda quite as much. Now, on the other hand, you don't have the depth perception. You're operating one-handed. Small risk due to thermal injury from the light source of the scope. And if you are someone who likes to use a micro drill, sometimes it can be a little challenging getting your drill and your endoscope in there together. A couple of studies that have looked at these outcomes, and the big take home here, again, not a real big difference in hearing outcomes regardless of the technique you use, but scutum removal was necessary in 74% of patients, and the chorda was actually sacrificed in about 7% of patients undergoing endoscopic ear surgery in this series. 8% of patients with dyschezia. You know, that's probably a little bit less, well, certainly less than what you see with standard microscopic approaches. I usually tell patients they have about a 30% risk of temporary dyschezia. I think long-term permanent dyschezia is pretty rare, and probably, you know, I bet I see it in less than 1 or 2% of patients. And then looking at another study, you know, does endoscopic stapedotomy increase hearing restoration rates compared to microscopic surgery? And in general, the answer is no. You know, we're trying to achieve the same outcome regardless of the technique. It's just a different way of doing that. I think probably the biggest thing is you probably are getting some decreased risk of chordotympany manipulation with an endoscope, and that's probably the biggest difference I would find between those two. Now, what about the technique itself? If you do a stapedotomy procedure, and some surgeons like to use a microdrill, some use a laser, some use a combination of both. When I trained, I was trained to sort of use a laser to make a rosette pattern in the footplate, to kind of weaken the footplate. And then we would use a skeeter drill after that to actually make the fenestra. Some surgeons prefer to just use the laser itself to make the fenestra. Looking at some outcomes, this is actually two systematic reviews comparing the use of a laser versus non-laser stapedotomy. And in general, there was really no difference in hearing outcomes between the two. Also looking at individual frequencies, and there was no real difference in vertigo outcomes. Without using a laser, there's a slight increased risk of footplate fracture. I'm sorry, guys. I think looking at this is actually a comparison of microdrill to laser. There was no difference in the hearing or really the vertigo, but a slight increased risk of footplate fracture as well as hearing loss with a microdrill, which that is actually kind of one of the reasons I stopped using the microdrill. If you've ever talked to someone who's had a stapedotomy with a drill, they'll tell you it's the loudest sound they've ever heard when you put that drill on the footplate. The other issue is, you know, when you drill through there, you're sort of swirling quite a bit of bone dust and bone debris around in there, and I just worry about it getting down into the vestibule a little bit. Clearly, it doesn't have a big impact on the hearing outcomes, but you know, certainly something to consider. The microdrill, however, is beneficial if you have a thickened footplate, and oftentimes you have to use it. You just can't laser through that much bone. One of the benefits, though, of the laser is if you do end up mobilizing that footplate, you can still use a laser to make your fenestra. And then, of course, if you use a memory-shaped prosthesis, the laser is quite advantageous to crimp your prosthesis. As far as the type of laser itself, there's sort of two primary categories: green light lasers, which typically are lasers such as the argon, KTP, or YAG laser, and then infrared lasers like the CO2 laser. The biggest difference is green light lasers are absorbed by pigmented tissues, whereas CO2 laser energy is absorbed by water. In general, a CO2 laser is felt to be safer around the inner ear because it's going to get absorbed by perilymphs before potentially injuring the neurovascular epithelium, such as the saccule. However, both lasers are certainly effective for use in otosclerosis surgery. I think one thing more and more we have to kind of keep in mind is the cost of these lasers. The fiber for a CO2 laser is quite expensive, and it hasn't quite deterred me from using it. But at some point, insurance companies may actually look at the cost. How much does it cost a patient to come have a surgery done by you versus someone else? And they may, if you are a more expensive surgeon and the cost such as equipment does go into that, then it may be more favorable for a patient to go elsewhere. So I think that's coming down the road, although it hasn't really affected us yet. Looking at outcomes based on different laser types, there really is no difference in hearing outcomes when you compare CO2 to the green light lasers. There's always just been this concern regarding the thermal effect of laser energy on the vestibule, regardless of laser type. And so oftentimes when you're using the laser, especially if it's a little bit thicker footplate, you want to have some pauses in between bursts of laser energy just to allow that footplate to cool a little bit. Looking at laser preferences in our survey, overwhelmingly the majority of surgeons were using the CO2 laser followed by KTP and then argon lasers. Now, oval window seals, typically we do recommend using some sort of tissue to seal around your prosthesis. This can vary from vein grafts to adipose tissue, fascia, perichondrium, and blood. This is actually a really cool device. This is from the Cos clinic in France. They developed this very low power suction here that's controlled with a foot pedal. This is a vein graft. You take your vein graft when it's wet and you kind of cut it and spread it out on a little block, and then you allow it to kind of get sucked into the lumen of this suction, and it forms a perfect little suction cup, and you then just place it right into your fenestra here when you do a small fenestra stapedotomy. If we look at the type of seal, oval window seal, Wyatt and colleagues looked at sort of short and long-term hearing using fat, fascia, and vein grafts. These were patients undergoing total stapedectomies. Hearing results were very similar no matter what tissue type you used, and there really was no difference in hearing outcomes based on the tissue itself. And that was, again, in total stapedectomies where you're having to cover the entire oval window with a graft. This was in our survey. We asked our respondents, what seal they used if they were performing a small fenestra stapedectomy or stapedotomy, and most people just used plain blood with no tissue at all, followed by adipose tissue and then subcutaneous tissue. When I trained, we would do small fenestra stapedotomies and have the anesthesiologist actually withdraw blood from a peripheral IV, and at the end of the case, you would just fill the entire middle ear with blood. Kind of gotten away with that. I actually always still put a little bit of, I usually take a little connective tissue from the thicker part of the tympanomeatal flap up high. I'll just go under the flap and trim off a little bit of tissue. And I always like to put a little bit of something around the prosthesis. I have had a patient once who developed a perilimb fistula after surgery, and ever since then I've made it kind of standard. But blood itself will form a clot and a seal around the prosthesis, and usually that is adequate. If you're doing a total stapedectomy or even a partial where you take out at least half the footplate, in that situation, of course, you should always put some form of tissue around your prosthesis or under the prosthesis. If in this survey, for those who did perform total stapedectomy, the majority were using perichondrium, followed by either vein, fat tissue, or blood. So some people were one person was just putting blood around the prosthesis on a total stapedectomy. And then the rest were using fascia. So perichondrium and fascia are the two most common tissues used. Now, if we look at the prosthesis design, this has changed quite a bit over the years, but really you can kind of currently break it down into two main types, either bucket handle type prostheses or your typical piston prosthesis with a shepherd's crook. Nitinol or memory-shaped prostheses have become very popular. These were developed to try to take the error out of crimping by the human hand. When we crimp, you basically are using an alligator and and the strength in your wrist and in your fingers, and it's very easy to overcrimp those prostheses. And so with nitinol, when you heat these prostheses, they assume a preformed shape, and it is to help reduce the risk of overcrimping. Other prostheses have been developed to also try to reduce the risk of over tightening that prosthesis and potential incus necrosis. This is a clip piston developed by Kurz. It's sort of like a little clothespin that slides on over the incus. A little bit about the nitinol prostheses. I think these have gained a lot of popularity just because of the ease of use, but it does require using some kind of heating filament to activate and self-crimp the prosthesis. The one issue with these, since they do assume a predetermined configuration, is if you have somebody with a really thin incus, sometimes it's pretty hard to get that prosthesis to actually go around and become a nice, secure fit. There is now the Olympus. It's a 360 prosthesis. It's developed to sort of so that when it crimps, it doesn't meet directly on the other side. It sort of curls around, and that has, I think, improved the outcome in some of these patients. But I have run into this as an issue in somebody who has a really narrow or thin incus. If you use the laser, you do want to be careful about how much you're lasering around the incus. Obviously, if you start really firing on the incus a whole lot, you run the risk of getting some thermal injury and potential necrosis. Nitinol has nickel in it. It's got about 5% nickel, and I think the rest is titanium. And so I always ask patients about nickel allergies prior to Stapes surgery just for that reason. I have seen someone actually get a reaction to one of these prostheses once. Looking at prosthesis types, this study by Arriaga and colleagues looked at the various top prostheses types, and really there's been shown to be no difference in audiologic outcomes between these prostheses. Regardless of what you use, you can counsel patients. They've got a 90% chance of success or a 10% failure rate. It is important to always take into consideration you want to do whatever you can to kind of minimize pressure on the lung process of the incus. And also, though, to have a firm enough connection that you're not getting excess vibration and the effect of sawing through the incus. Looking at, this is prosthesis type based on total stapedectomy procedures. 76% of respondents continue to use a piston prosthesis, followed by 24% using bucket handles. So, I mean, I think there has been a pretty big shift to using pistons currently. There have been several studies looking at the diameter of your piston. Piston prostheses come in a variety of diameters from 0.4 up to 0.8 millimeters in diameter. In general, if you're doing a total stapedectomy, there really is no difference, and that makes sense. You've taken out the whole foot plate, and it really doesn't matter how big that diameter is. But if you're doing a stapedotomy, it does actually make a difference. And if you think about it, the diameter of that piston and the amount of pressure it can apply through your stapedotomy can have an effect on your ultimate hearing outcome. And in general, with a smaller prosthesis, like a 0.4 millimeter diameter prosthesis, you do get some improvement in your high frequency gain above 4,000 hertz. On the other hand, in the very lows, with a 0.4, you don't get quite as good a closure as you do with, say, a 0.6 millimeter prosthesis. And so overall hearing results tend to be a little bit better air-bone gap closure with a slightly larger prosthesis like a 0.6. I actually split the difference and I use a 0.5, which seems to give me pretty consistent and reliable results. So let's look at some controversial candidates for surgery. In children, it can be a little bit sometimes difficult on knowing when to operate on these patients. And there can be different reasons why they have Stapes fixation. Two of the most common reasons are congenital Stapes fixation versus juvenile otosclerosis. When it's a congenital Stapes fixation, the hearing loss tends to be non-progressive. This is diagnosed earlier, typically around age 3, and it's a pretty consistent hearing loss that doesn't change, as opposed to juvenile otosclerosis, which usually presents a little bit later, and the hearing loss is progressive. Keep in mind that with congenital stapes fixation, you're more likely to have other ossicular abnormalities, such as abnormalities of the incus and malleus. And then you should also be thinking about in a child X-linked hearing loss, which is associated with stapes fixation, as well as a widened medialis and the risk of a perilymph gusher. So, in adults, I never image adults unless there's something really unusual about their hearing loss or their history. However, if I have a child who has no real reason for a conductive hearing loss, and I am assuming it's some form of stapes fixation, I do always scan these kids if I'm only if if I were, and I'm talking about children between, say, age 6 and a teenage year who I'm considering operating on, I would always get a scan first. If you look at outcomes in children, this was one of the larger early studies by Dela Cruz back in 1999. He looked at 95 ears in kids with stapes fixation. In patients with juvenile otosclerosis, 82% had an airborne gap closure to less than 10 dBs, but with congenital stapes fixation, it's much less than that, 44%. And so the reason for that is you do have a greater incidence of other issues, ossicular malformations and congenital stapes fixation. In this series, there were no cases of profound hearing loss, and you can counsel patients that a good outcome can be expected in about 75% of the time. This is a meta-analysis looking at surgical success rates in congenital stapes fixation versus juvenile otosclerosis. They looked at 445 ears and a little over half juvenile otosclerosis, the remaining with congenital stapes fixation. And again, you see that you get much better outcomes if it's juvenile otosclerosis compared to congenital stapes fixation. So in this patient population, if these kids are presenting really early, between ages of 3 and 6, and this hearing loss seems like it's been there and hasn't changed, those are patients you really may want to consider waiting until they get a bit older before considering any type of surgery. And certainly you want to scan those patients. So in general recommendations, wait until these patients are at least age 5. I think that's a general rule we use for most middle ear surgery in kids. In a lot of these patients, I'll wait till they even get a little bit older. I don't think for a conductive hearing loss there's really that big of a rush, unless, of course, it's bilateral and it's a significant conductive hearing loss. If it's unilateral, of course, consider a hearing aid and wait till they're older. Parents really need to be counseled about these potential risks. Now, Meniere's disease has always been a little bit controversial. Somebody who has classic findings of airborne gap and an assumed otosclerosis, but they've got also fluctuating bone conduction thresholds consistent with Meniere's disease. The concern has always been that if the saccule is dilated and it's sort of pressed up against the foot plate, which you can kind of see here, and then you go ahead and you do either a stapedectomy or stapedotomy, you risk rupturing the saccule and getting a dead ear in that situation. So I was always sort of taught that in patients with Meniere's disease, it's better to hold off on those. There have been a couple studies looking at outcomes of Stapes surgery in patients with Meniere's disease. In this particular one, this is an early study back in the 80s, and they looked at a postmortem study of 8 temporal bones with Meniere's disease and felt that if their bone conduction thresholds were 35 dBs or better at 500 hertz, and they had no high-frequency hearing loss, that stapedectomy was not an increased risk. However, stapedectomy should not be performed if you have thresholds greater than 45 dBs at 500 hertz, which obviously if they're getting in this range, the thought is they actually have active high drops during that time, and they're at an increased risk of having problems. John Shea looked at his, I think he did in his lifetime something like over 20,000 stapedectomies, but he looked at his patients with Meniere's disease, and his recommendation was, you control their symptoms. They have to have good control of their cochlear hydrops or Meniere symptoms for at least 1 year, as evidenced by audiograms, and he was also using electrocochleography. And if they were stable for up to a year and stable at the time, then he felt there was a reduced risk of hearing loss with stapedectomy. In general, it's not that often you're going to see these patients, but I have seen a few, and if they have active disease, I tend to recommend not doing surgery. However, if their Meniere's really seems to stabilize and you know they've gone a good year or more without any fluctuation or vertigo symptoms, then I do think it's reasonable to consider it. Now, let's look a little bit at patients who are candidates for revision Stapes surgery. With revision surgery, you know, your outcomes every time you go back in that ear become less. And typically we say the first go around, you got a 90 to 95% chance of success. Second go around, 85 to 90, and third revision, anywhere from 75 to 80% chance of success. A displaced prosthesis is the most common reason for this, and the most common reason for displaced prosthesis, of course, is necrosis of the long process of the Incus. There's two reasons this, or really three, but the main two reasons this happens is either you have a loose crimp of the prosthesis, and then that wire loop sort of saws through the Incus, and that creates notching, or if it's crimped on too firmly, you get necrosis of the distal end of the Incus, and then the prosthesis slips off. Another possible reason for failure is if the prosthesis was ever so slightly short, you'll get regrowth of bone actually under the fenestra, and that'll seal off your fenestra, and the conductive hearing loss returns. So just showing some examples, this is kind of classic notching through the Incus. You get failures with bucket handles too. One of the proponents of bucket handles report they like this because you don't get that risk of necrosis of the Incus, but these fail as well. And oftentimes you're sort of left with this scenario when you get back in there. What can you do about Incus necrosis? Well, there are actually some pretty good things you can do to still revise these ears. One is just using bone cement, which is if I have enough Incus remaining, you can actually build this Incus back up again with hydroxyapatite cement. And so that's what this video down below is demonstrating. The cement has set. You got to give it at least a good 6 to 8 minutes to kind of set and harden. And this is a situation where I think you have to use a nitinol type prosthesis, because if you try to crimp that cement usually hasn't hardened enough that it's not going to fracture. And I've had pretty good success using this for revision cases if you have Incus necrosis. There's actual prostheses to help with this. This is called a K-helix prosthesis. This little wire loop can be elongated to try to get it to fit onto the Incus. And then it has a piston at the other end that can be angled into the fenestra. You do tend to still need a little bit of cement to secure this wire loop, however, onto the Incus. And then this is something I actually really like, this prosthesis. Fortunately, I don't have to use it too much, but historically, if a lot of the Incus was necrosed and you really didn't have enough Incus remaining to put a traditional prosthesis on, you'd have to put one of these. This is called an IRP, an Incus replacement prosthesis. And it was basically a wire loop at this end and then a little wire loop ring at the other. And you would have to make a subperiosteal pocket under the malleus, loop this wire loop around, and then try to twist it on itself. And they were really notoriously difficult to place. And then, of course, leave it up to the Germans to create something as well engineered as this. This is a clip type prosthesis that goes onto the malleus, and then it has a ball joint here. So the first thing you do is clip this in place, and then with this ball joint, you can swivel this piston into your fenestra. I'm not going to show this whole thing, but this is a left ear, and I'm using a one knife to kind of get into a subperiosteal plane. This is the short process of the malleus. The manubrium is coming down here. And I've made a little pocket between the undersurface of the eardrum and that malleus. And so now I'm just getting the kind of that prosthesis in place, and then you've got to get this clip portion onto the malleus. And this is the part that is sometimes a bit tricky. And so you'll see it kind of pop on right here in a second. And then, so it clips on, and then once it's on, you can then maneuver that little piston via the ball joint into the, there's the ball joint there, and then it kind of comes back at you, and then it kind of right angles down into your fenestra. And those work pretty well. little tricky to place though. And of course, if all else fails, you can always do a TORP, especially if the patient's had a total stapedectomy before. You've got a nice tissue graft over the oval window. Just place a TORP. Sometimes you get the best hearing results you can get with a TORP if you've done a stapedectomy. Now, moving on, we'll talk a little bit about postoperative care. You know, there's some controversies here whether to give antibiotics or steroids. There have been several, pretty good reviews that really have not shown any major evidence to support perioperative antibiotic therapy or perioperative steroid therapy during Stapes surgery. That being said, I always give everyone intraoperative antibiotics. I think that's I think we should do that. And I actually do give everyone a dose of Decadron at the time of surgery. Anything you do to the inner ear where you're manipulating the inner ear fluids, I think you're at risk of getting a little bit of inflammation, and if nothing else, it may just help reduce some of that inflammatory response. Patients will always ask, is it safe for me to dive? I like to scuba dive. Can I have this surgery? And there's sort of two camps on this. You'll find some of your faculty will say absolutely not, no scuba diving. That should actually be when scuba diver flies. This is pertaining to pilots. But there have been several studies now that have looked at both of these, scuba diving or even skydiving and Stapes surgery. And really, there hasn't been shown to be any increased risk. This was a survey by the American Otologic Society in 1996, and 54%, so half or a little over, recommended a permanent restriction to scuba diving after Stapes surgery. John House Clinic looked at all of their Stapes patients and identified those who participated in sports such as scuba diving, and found that it was pretty rare that anyone had any significant major issues or major hearing loss. And so conclusion is that if a person has adequate eustachian tube function and they use safe practices, diving or scuba diving, meaning that they know how to Valsalva, clear their ears properly, then in general it's okay for those patients to continue participating in sports like this after having surgery. A couple of other studies have looked at actual pilots and high performance pilots following Stapes surgery. This one looked at U.S. Air Force crewmen. This was a study out of Israel that looked at fighter pilots who flew fighter aircraft, and all of these patients had Stapes procedures with a vein graft. They all returned to flight duty without any adverse symptoms or effects as a result of undergoing stapedectomy. So in general, when counseling patients, the thing that tends to come up most is, is it safe for me to dive? I like to scuba dive. Is this going to cause problems? And so I counsel them, yeah, there's always a risk. It's nothing's 100% risk-free, but if you practice safe diving technique, you properly clear your ears, you don't descend without being able to clear your ears, then in general, it's considered to be safe. I do, if I know someone is, prior to surgery is already involved in these sports, I often will take a little extra precaution, making sure I put enough tissue around the prosthesis. So in summary, stapedectomy surgery is safe, it's reliable, it's a great treatment for patients with otosclerosis. There are a lot of different techniques that can be used to perform a stapedotomy or stapedectomy, and I think the hearing results are equally good regardless of the technique you use. We continue to make advances in Stapes surgery now with endoscopic, techniques and continued use of lasers. I think the most important thing here is once you find a technique and something that works for you, if you're getting the hearing outcomes that you want, then stay with those techniques. And then finally, make sure you keep the patient informed of all of their options. It's very important to still discuss with them. A hearing aid is a good option for somebody who has otosclerosis. It will adequately treat their hearing loss, and I think everyone, in addition to being talked to about surgery, should also have a discussion of hearing aids. I am happy to take any questions.
Awesome talk, Dr. Cunningham. Thank you so much. I've got a couple, but I'll kind of open it up to the floor for anyone out there who has a question.
Judy, I know you have a question. Ted, I know you.
Yeah, I'm insulted. She's never showed up to any of my lectures.
Yeah, I was wondering what role the MVP piston might play in a scapular flap.
Fortunately, it has absolutely no role whatsoever. The role it has is convincing you that you don't want to do scapula flaps.
You could have said it shorter.
Nice. Chili, that was excellent
Great
talk
talk,
as
yeah.
usual. I learned all sorts of things.
Thank you, Judy.
Somebody's got a hand up. Dr. Macias.
Yeah, I have a question. Does the addition of the nitinol prosthesis, does that change your prosthesis length, like the length that you would put in?
Yeah, that's a good question. So in general, you know, if you use a piston, and especially if you crimp a piston, a standard piston, typically you measure and then you subtract 0.25 from the length of the prosthesis. And the reason for that is at least depending on the measuring rod you use, most measuring rods you're measuring from the top of the incus down, but those pistons are sized based on the level where the loop begins. So they're 0.25 shorter than the length from the incus, the top of the incus down. So typically you measure and then you subtract 0.25 and that's the length you use. With a nitinol, they do shrink a little bit. And so I didn't initially, but after I started using them for a while, if I measure, let's say from the top of the incus to the foot plate is 4.25, I'll put a 4.25 prosthesis in.
Yeah, those measurements are interesting. Bruce always used a 4.25. With the bucket handle, Paul always uses a 4. Yeah. Larry Lustig always uses a 4.5. I tend to measure and use what I feel is an appropriate length for the patient.
Yeah, I think it's good to measure. Every now and then you'll be surprised. You'll find somebody who's got like a 3.75 length or something. Really, that if you use a standard length, you'll find it short, which is, I mean, you'll probably recognize that when you place it, but it's probably good to measure anyway. Unless your OR likes you stocking just one size prosthesis, which, you know, we may see more stuff like that down the road.
In looking at some of the photos of the otomimics distal incus necrosis, it looked like there was quite a bit build out of the incus. Do you have any sense of what the durability of revision in those cases are? I don't know the literature on that. And
yeah, I don't think anyone has really looked at that. My sort of general rule for that is I think you need at least 2/3 to half the length of the incus. If you go shorter than about half the length of the incus, I think at that point you're building out so much that it does become unstable. Now, part of what in that video, some of that is bones. You carry that bone cement. You place it kind of up high, kind of as close to the body as you can, and then you bring it down and you kind of build it out that way. So it's kind of got a little bit of a scaffolding extending along the remaining length of incus to try to secure it there. But for a Stapes, you would if I were going to, you can get away with a little bit more sometimes if you're doing, for example, incus necrosis and the Stapes is normal. I'll use it for that for OCRs. But if you're actually putting a Stapes prosthesis on it, you probably really need at least half to 2/3 of that incus remaining. And a lot of times there's enough incus there that you can actually get your prosthesis on, but it's literally just like right at the tip of where that necrosis occurs. And in that case, you can get it on there and then just put a little drop of bone cement on the wire loop and it'll secure it there and keep it from being able to move.
Seal it. Thanks.
Sure.
Hi, Cal.
Yes.
It's John Carey.
Oh, hey.
Great talk, very comprehensive. I really enjoyed it. I have a question about the systemic nature of this, and what's the role of bisphosphonates or other rank ligand agents. So I'm thinking about the patient who has bilateral otosclerosis, maybe some degree of sensory neural hearing loss. What's your approach with them, and do you change the workup at all? Do you change the timing of surgery, and do you consider bisphosphonates?
Yeah, that's a good question. If it's someone who primarily has a conductive component to their hearing, yet they are also showing possible sensory neural component to it as well. A lot of times, especially if it's a significant sensory neural component, I will occasionally scan those patients just to look to see, how involved the otic capsule appears. If it's a large air bone gap, a lot of times I'll offer surgery to try to correct their, and especially if it's the first, like if I'm recently seeing them, I'll offer surgery to correct the conductive component. And then I may elect to, depending on their hearing outcome, I may elect to follow the sensory neural hearing for a little while. And if I see progression of it, then I will talk to them about bisphosphonates. For the residents or fellows, historically, we always used to use Florical, a fluoride supplement, to try to stabilize sensory neural levels in these patients. And then there were various other forms. Monocal was another one that was used for a while. And I think, there's very limited data on just how effective that was. Those recommendations came from just a few studies. Some of the more current literature, though, looking at bisphosphonates shows that they can be very beneficial to help stabilize the sensory neural hearing levels in these patients. However, there are certain side effects and risks of these medications that you have to discuss with the patients and weigh whether, is the degree of sensory neural progression, hearing loss progression that they're experiencing, is it worth those risks? But if it's somebody who I think purely has a sensory neural form or cochlear otosclerosis, and it seems to be progressing at a fairly high rate, then those are patients I do discuss bisphosphonate therapy with. I admit we have a rheumatologist here that I work with a lot of otologic issues, and sometimes I'll get them involved to kind of help manage some of that.
Thanks. Yeah, I'm fortunate to have a good bone endocrinologist who has taught me a lot about this, and so I refer patients to her, and she likes to get a bone metabolic workup, obviously bone density scanning. I don't find it changes my surgical plans that often, but it is helpful, and I do encourage these patients who have bilateral otosclerosis to get early bone densitometry studies. And, surprisingly often you pick up people who didn't know they had osteoporosis or osteopenia.
Do you do that? Are you doing that even like if they have bilateral otosclerosis before they have significant sensory neural loss?
So that's a good question. I don't know. I think the typical history is, you get a woman in her 30s who, has a couple of pregnancies and that's accelerated their otosclerosis, and that's your snapshot in time. You don't know if they're going to go on to develop sensory neural hearing loss. What's their risk? I've been monitoring them, and if they develop sensory neural hearing loss, then I pull that trigger and send them to the endocrine specialist, because they don't seem to have the capacity to see that many patients.
Right.
And insurance is really problematic about getting a bone workup before they're 50 years old.
Right. I think I would agree. I in those patients, if I start to see their sensory neural levels, or even if somebody who's had stapedectomy, years ago, and now they're coming complaining that their hearing's getting worse, and it appears to be more of a sensory neural loss. I'll work those patients up further.
Thanks.
Oh yeah, thank you.
All right, Dr. Cunningham, I think it looks like we are out of questions there.
Sure.
Awesome talk. Thank you so much again. It was a pleasure to have you.
Thank you for having me, and thank you for putting this together. It's been great.
All right, everyone, take care.
Ted?
Thanks, Cal. Appreciate it.
Thanks, Cal. Appreciate it.
Sure thing.
Thank you. Good night.
Thanks, Cal.